My name is Dr. Lakshmi from OBG department. My topic is pathological vaginal discharge. So we'll deal with these topics, that is introduction, then differential diagnosis, and what you all have to take the history, overview of this differential DD. Introduction, common presentation of women to the STI clinic. It can be physiological or pathological, related with some common sexually transmitted diseases. Then vaginal discharge, what is it? It is the secretions produced by the glands of vaginal wall and cervix that drain from the vaginal opening. So this is the picture of the female reproductive system. Differential diagnosis. Vaginal discharge of two types, non-infective and infective. In the infective, it might be sexually transmitted infections or non-sexually transmitted infections. So non-infectious causes might be which is physiological, which is mid-cycle discharge and due to sexual arousal and during pregnancies, and others being due to cervical polyps, foreign bodies, that is retained tampon or conception, then vulval dermatitis, chemical irritation, IUCD use, oral contraceptive use. Infectious vaginal discharge, sexually transmitted and non-sexually transmitted. In that sexually transmitted, we have chlamydia, gonorrhea, herpes simplex, trichomoniasis, vulvovaginal candidiasis. Physiological vaginal discharge, it is white or clear. It might be thick or thin, mostly odorless or slight odor, which is a normal vaginal discharge in reproductive aged women. In history taking, we have to ask for the color, odor, presence of blood, and relationship to the menstrual cycle and associated symptoms. You should also take past medical history, sexual history, obstetric history, gynecological history, contraceptive history, menstrual history, drug history, family history, and social history. So the nature of discharge, if it is clear or white, then it is physiological. If it is mucopurulent, then it might be due to gonorrhea, pelvic inflammatory disease, chlamydia. If it is thick and curd, it is vulvovaginal candidiasis. If it is frothy, yellowish green, then it is trichomoniasis. Grayish white, then it is due to bacterial vaginosis. So you have to examine the patient in the lithotomy position, and it should be a per speculum examination. And you have to see for the color, odor, and nature of discharge. And you have to inspect the cervix also. So if there are any cervical erosion, cervical polyp, and some cases cervical CA also, there may be the small odorous vaginal discharge with the patient might be complaining. So per speculum examination in a vaginal discharge, that is pathological vaginal discharge patient, is very much important. We should never skip a per speculum examination, which should be followed with a per vaginal examination to see for the cervical motion tenderness or uterine tenderness or POD, any tenderness. Next, overview of the differential diagnosis, one by one we'll take up. That is, gonorrhea is one of the causes. Clinical features, it is an endocervical mucopurulent discharge. When it is complicated with PID, we can have dysuria, lower abdominal pain, postcoital and intermenstrual bleeding. Gonococcal infection, the pathogen is Neisseria gonorrhoeae. Intracellular gram-negative diplococci mainly affect the endocervix. 50% of females are asymptomatic. Incubation period is 2 to 7 days. Common age of onset is 15 to 24. What are the complications? Bartholin's abscess, pelvic inflammatory disease due to ascending infection, disseminated gonococcal infection like fever, septic arthritis, blisters near small joint, perihepatitis, infertility, mother-to-child transmission is ophthalmia neonatal. So we have to take the endocervical swab and vulvovaginal swab also for NAT. Okay. Then microscopy, it reveals gram-negative intracellular diplococci. It is a rapid diagnosis. Microscopy is a rapid diagnosis. Then you give for the culture, which is Thayer-Martin medium. And NAT is nucleic acid amplification test. Treatment, cefixime 4 mg start and IV ceftriaxone can be given. Partner tracing and treating the partner is also very much important. Then avoiding sexual intercourse is important for some time. Next is chlamydia. This is also an STI. It has a purulent or mucopurulent discharge. Same thing, when it is complicated with PID, you have all the symptoms of PID. So the serowarts are D to K, gram-negative, obligatory intracellular bacteria. Nearly 70% of female are asymptomatic. What are the complications? It is PID, and it might cause ectopic pregnancy and infertility also. It causes perihepatitis, sexually acquired reactive arthritis. In pregnancy, it might cause preterm births, postpartum infections, ophthalmia, neonatal. Same thing, we'll take an endocervical and a vulvovaginal swab. In the microscopy, we have a polymorphonuclear leukocytes which are more than 30 under high power in absence of intracellular diplococci diagnosed as non-gonococcal cervicitis. What is diagnostic is NAT. Doxycycline 100 mg BD for 7 days or azithromycin 1 gram stat. Azithromycin during pregnancy. Partner tracing and epidemiological treatment to the partner. Avoid sexual relationship. The other one being trichomoniasis. There will be profuse frothy yellow or grey discharge with foul odor. You will be having dysuria, abdominal discomfort, vulval itching, dyspareunia. Then the classic cervix, which is described as strawberry cervix with multiple hemorrhagic areas in the cervix. It is classical for trichomoniasis. Trichomonas vaginalis is the infection. Causes trichomoniasis, most common STI in the worldwide. It is a flagellated protozoa. It mainly affects vagina, urethra and paraurethral glands. 10 to 50% of female, they are asymptomatic. So complications in pregnancy, as we said earlier. Sample should be taken from the posterior fornix and we have to observe under microscope. Prepare a wet smear that is with normal saline, observed for motility. Flagellated organism immediately staining with Giemsa and culture with modified diamond TYM medium. Treatment is metronidazole 400 mg BD for 7 days. Partner tracing and treating the partner also. The next thing which you see common in our OPD is vulvovaginal candidiasis. It is a fungal infection, oval budding fungus, pathogen it is, 80 to 92% Candida albicans, non-albicans species being Candida glabrata, Candida tropicalis and even yeast. Clinical features is thick, white, curdy-like, non-offensive vaginal discharge, vulval itching, vulval soreness, superficial dyspareunia due to vulval irritation, signs being erythema, fissuring, vulval edema. Predisposing factors is diabetes mellitus, long-term steroids, pregnancy, prolonged antibiotic use, immune suppression. Samples we have to take is vaginal swab from lateral fornix. Investigations, microscope of vaginal smear, that is gram stain, wet film examination under KOH, hyphae and spores. Culture should be done in subaurate agar medium. Treatment, oral triazoles, fluconazole 150 mg stat or itraconazole 200 mg BD. Topical applications play a role over here, that is clotrimazole, miconazole and statin. Pessaries are also available, but here there is no epidermal treatment for the partner. Bacterial vaginosis, it is non-sexually transmitted infection, frequent cause for vaginal discharge. Anaerobic or facultative aerobic bacteria, normal vaginal flora of lactobacilli are replaced by the overgrowth of Gardnerella vaginalis, then Mycoplasma and Mobilincus. Vaginal pH is more than 4.5. Clinical features is greyish white homogeneous vaginal discharge, offensive fishy odor, no vaginal inflammation. Predisposing factors, vaginal douching, then smoking, antibiotic use, recent change in the sex partner, IUCD. Investigations is microscopy, gram stain smear of vaginal discharge, presence of clue cells. These are the diagnostic criteria for bacterial vaginosis. It's also called as Amsel's criteria. That is presence of clue cells on microscopic examination. Clue cells are epithelial cells covered with bacteria, giving a characteristic stripped appearance on examination. Yellowish grey discharge seen on naked eye examination. Vaginal pH more than 4.5. Release of characteristic fishy odor on addition of alkali, that is 10% KOH. For diagnosis of bacterial vaginosis, at least 3 criteria should be present. Treatment is metronidazole 400 mg for 7 days. Non-infective causes of vaginal discharge being retained foreign bodies and cervical polyps. Thank you.